Great. Well, thank you all for being here. It's always it's a delight to be back in Madison. And I'm excited to have the opportunity to share some of my research with you all. So I wanted to start with these two paintings by George Seurat. You may be familiar with the famous A Sunday on the Grand Jacques over there on your right. Before he painted that scene, he painted this painting called The Bathers at Sears, and it's actually the same Seine River that you see in both of these images. When you put them next to each other, I think it nicely illustrates social class differences and living conditions and leisure activities for two areas that are quite close geographically. And the foundation for my research rests on the well-established link between social class and health. So a brief outline, I will briefly touch on what we know about health inequalities, what are some of the evidence, but then I'll quickly transition to my work on the role of psychological factors in the context of health inequalities. Talk about how risk gets under the skin, and focus in particular on how the cardiovascular system's response to stress as an important pathway, conclude with some directions of where this work is going and some take-home messages. So here are data representing women in the United States as a function of age and educational attainment. And here the vertical axis represents the percentage of higher mortality rate relative to women with at least 17 years or more than a college degree of education. And so the light blue bars are those who have less than 8 years of education, and as the blue bars get darker, education is increasing. And what you can see across different age groups is that as education increases, that mortality difference is declining. An important takeaway from this slide is that it's not just a story about haves and have-nots, but this is a graded association, and so every bump up in education is associated with some mortality benefit on average. Here's another look. These are different data from the National Health Interview Survey. Here we have the percentage of individuals over the age of 25 who have coronary heart disease as a function of family income. So the white bars here represent families whose income falls below the federal poverty level, and as the bars get darker, family income is increasing. So again, what you see when you look at the total sample, or when you separate it out by race or ethnicity, we have Black, Hispanic, and white here, or again, you see those graded associations. Now, I came to graduate school here at the University of Wisconsin in the psychology department to try to understand complex relationships between these pervasive health inequalities, consider psychological risk and resilience factors, and pay attention to biological processes that we know contribute to chronic diseases of aging, things like cardiovascular disease and diabetes. Now, a non-trivial factor when you want to combine all of those different types of research is finding a sample or a data set that measures social, psychological, and biological factors well. And that's where the MIDAS study really played an important role. So we'll go through this briefly since you've already, this is not your first aging colloquium, you probably know about the MIDAS study run here out of the University of Wisconsin. MIDAS began in 1995 with a large sample of American adults between the ages of 25 and 74. They were followed up again in 2004, but importantly at this second wave, a subset of participants came in for an overnight clinic visit at one of 3 hospitals around the country, either here at UW, at Georgetown, or at UCLA. And 1,255 individuals provided a fasting blood sample and provided in-depth biological assessments. And so it's primarily that data that I'll be presenting today. And then just for completeness, MIDAS 3 was completed, or began in 2013, and biological data collection for a second round is ongoing right now. Now, one of the components from the biological data that we collected from those fasting blood samples were markers of inflammation. And inflammation is a really important biological process that we think contributes to the development and the progression of a lot of those chronic diseases of aging. So I previously showed you evidence that there are socioeconomic gradients with morbidity and mortality, but it's also true that these gradients exist with biological factors that contribute to disease pathophysiology. And so this graph represents serum levels of interleukin-6. This is one marker of inflammation as a function of educational status. So you can see is that individuals with higher education have relatively lower levels of IL-6, which would be predictive of lower risk for things like cardiovascular disease and diabetes. So despite these robust socioeconomic gradients in most markers of health and health risk, it's also true that there's an enormous amount of heterogeneity in health, of variability within socioeconomic strata. So not all low SES individuals have poor health. And one thing that I've asked in my research is whether knowing something about our psychological factors may help us identify who may be especially vulnerable and who may be resilient in the context of health inequalities. So for the studies that I'm going to present today, our goal was to examine anger as an aggravator and psychological well-being as a potential buffer of these health inequalities. Now, the idea that anger is relevant for health is not a new idea. Ancient Greek and Roman philosophers like Aristotle and Seneca wrote about the effects of anger. One quote I really like. So Seneca, a first century Roman philosopher, wrote, "This rather is what we ought to realize, how many men anger in and of itself has injured. Some through too much passion have burst their veins, and sickly people have fallen back into illnesses." Anger has also been the study of scientific and medical discourse for over a century. An article published in the Journal of the American Medical Association, which is the premier medical journal in this country, in 1896 was titled "The Physiologic Effects of the Indulgence in Anger." And I know you may not be able to read this, so I'll read just a section for you. "So it sometimes happens that a man falls dead in a fit of rage, and it is said perhaps that he had a weak heart, which could not stand the strain imposed by his mental state. Nobody seems to think that this is but the culmination of a long series of such fits of madness which have themselves caused the weakness in question." Now, there's a very long and interesting history in contemporary science thinking about anger and hostility as they relate to health, especially cardiovascular health. Suffice to say that individuals who have greater anger, who are more hostile, do tend to show poorer health outcomes. So they have higher blood pressure, higher rates of cardiovascular disease, and also higher levels of inflammation. However, most of the research that's been done on anger and health has largely ignored the socioeconomic context. And I think this is a really important oversight. Anger is an especially relevant emotion in the context of inequality. When you look at what causes people to be angry, things like blocked goals and frustrations often fuel that. And so one of the questions that we asked was whether relationships between anger and health were consistent across the entire socioeconomic hierarchy, or whether they might be more pronounced among those at the lower end. So here's one example finding. Let me walk you through this graph because you'll see a few more like it. Here you have levels of interleukin-6, that inflammatory marker, on the vertical axis, where higher levels are predictive of greater cardiovascular risk. You have one dimension of anger. This is that when you feel angry, you choose to express it outwardly. You yell or you hit when you feel anger. And those lines represent the relationship between anger and IL-6 for individuals categorized by their level of educational attainment, where the red line are those individuals who have a high school education or less, the yellow line are those with some college, and the white line are those with a college degree. And what you can see when we control for things like age, sex, health status, and health behaviors is that there's a relationship between expressing anger outwardly and interleukin-6 for the less educated only. So this red line here, and for individuals who have relatively high education, there's no link between anger and IL-6. That was just one example. We have several studies on this topic. In general, to summarize, so trait anger and outward expression of anger have been associated with inflammation consistently among the less educated. We found evidence that being able to control or manage anger seemed to be protective, that is, to predict the lower levels of interleukin-6 among less educated women. We've also extended this idea to consider whether individual differences in how you express your anger may change relationships between age and metabolic syndrome in this case. And I think this came up earlier, but for those who are not familiar, metabolic syndrome is a clustering of risk factors, things like central adiposity, high blood pressure, high blood glucose, and dysregulated cholesterol. And we know that older adults tend to they experience less anger, and they report being able to better manage their anger. We also know that older adults have higher rates of metabolic syndrome. And so our question was, do older adults who report high anger, do they kind of exacerbate or make their age-related risk worse? And indeed, that's what we found. Whereas older adults who reported relatively low levels of anger expression had comparable rates of metabolic syndrome to adults several decades younger than them. I think the big takeaway from this part is to say that the social context is really critical for understanding these linkages between anger and health. So now we're going to switch gears a little bit and talk about protective factors. And to do that, I want to introduce two related but distinct varieties of well-being. The first is hedonic well-being, depicted here by the beautiful garden of earthly delights. Hedonic well-being derives from the term hedonia, refers to ideas about pursuing pleasure and happiness. This was described by ancient Greek philosophers who wrote that the central goal of life was really to maximize pleasure and to attain a happy, tranquil life. And we can contrast that with eudaimonic well-being, depicted by Raphael's School of Athens over there. And eudaimonic well-being dates back to Aristotle's writings on eudaimonia, which Aristotle called the greatest of all human goods. And Aristotle argued that living a good life was not just about being happy or satisfying our appetites, but rather the good life came from finding the best within ourselves and then living a life in accordance with those values. Now, in contemporary research, we can measure both hedonic and eudaimonic well-being. Hedonic well-being is typically assessed with psychological scales of happiness and life satisfaction. Some example items to give you a flavor for what this looks like. So we might ask individuals to rate how much of the last month they felt cheerful or full of life, or how much of the time they felt like they were having a lot of fun. If you've been to previous aging colloquium, you may know about eudaimonic well-being. It was really best characterized by Dr. Riff, who posed a 6-factor model of eudaimonic well-being, with these dimensions being autonomy, environmental mastery, personal growth, positive relations with others, purpose in life, and self-acceptance. And a few example items here. So we might ask participants or individuals the extent to which they agree with these statements. For me, life has been a continuous process of learning, changing, and growth. This would be an example item from the personal growth dimension. Ask people how much they agree with the statement. Most people see me as loving and affectionate. An example item from the positive relations with others scale. And finally, I'm quite good at managing the many responsibilities of my daily life. An example item from that environmental mastery dimension. Now, both hedonic and eudaimonic well-being have been linked with lower morbidity and mortality, and a growing body of work, including some of my own, has been linking well-being to some of these intermediate biological processes that we think contribute to disease pathophysiology. So, for example, how individuals with higher well-being have fewer cardiovascular events, lower all-cause mortality, better physical functioning, and lower risk for Alzheimer's disease. In terms of intermediate biological pathways, we see that individuals with higher well-being have lower risk of metabolic syndrome, that clustering of risk factors I described earlier, lower inflammatory markers, and better lipid profiles. So one of the research questions that we had was whether these linkages between well-being and health were consistent across the socioeconomic gradient, or whether they might be especially pronounced kind of in the context of inequality. And so here's an example finding. Again, we have levels of interleukin-6 on the vertical axis, where higher levels are indicative of greater risk. Purpose in life here, one dimension of eudaimonic well-being on the horizontal axis. And the lines represent individuals with different levels of educational attainment. So what you can see is that for relatively less educated individuals, there is this inverse association where individuals with higher levels of purpose in life have relatively low levels of IL-6. Looking at this another way, when you look at individuals who report relatively low levels of purpose in life, so down here, you see those expected educational gradients and levels of IL-6. But contrast that to when you look at individuals reporting relatively high purpose in life, those gradients are attenuated. We didn't just see this for purpose in life. This pattern emerged consistent across a variety of dimensions of both hedonic and eudaimonic well-being. Showed similar patterns for positive affect, environmental mastery, self-acceptance, and positive relations with others. Okay, to briefly summarize this part. So well-being has been associated with lower levels of inflammation among the less educated. And I think together with the findings on anger, it raises the question of whether teaching anger management or promoting psychological well-being will confer physical health benefits, and maybe these might be pronounced among those who are socioeconomically disadvantaged. So the models that I just showed you have been really helpful for identifying who is especially vulnerable and resilient, but what they don't do well are consider the biological and behavioral pathways that link socioeconomic status to health. And so we're going to transition to start thinking more about those pathways. To do this, you have to have a great team of collaborators and also be willing to work across methods and from different disciplines. So those previous examples were really kind of population-based studies to try to understand linkages between socioeconomic status and biological risk factors. For the rest of the time, we're going to be talking about methods happening in the lab to examine how the cardiovascular system reacts and recovers to stress in real time as a potential pathway. So we can measure different aspects of your cardiovascular system and how it responds to stress by using tools from psychophysiology. We can put a blood pressure cuff on your arm, electrodes on your chest and back, and collect things like electrocardiogram and impedance cardiography, which provide really nice in-depth measures of the biological responses to stress. Now, one of the cardinal rules in stress research is that there is a lot of variability. This might be intuitive to you all. We all have friends or relatives who are relatively nonchalant about the slings and arrows that life throws at us, but we also know people who get really hot and bothered and just stay aggravated about relatively small things. So I think these ideas of variability are pretty intuitive. So there's a lot of individual differences in how people react to the same stressor and how quickly or how easily they're able to recover. So what I have here for you are 4 hypothetical participants. We have some kind of physiological measure of stress here on the vertical axis, something like heart rate or blood pressure. And what we have on the vertical axis here is time. And I've depicted by those bars what's happening when you're encountering a stressor, and then that stressor goes away in the lab, and we're able to measure these things to see how long and how quickly you recover. So if you start by comparing 2 participants, A and B, this is the blue and the white line, you see that they have an identical reaction to the stressor that we throw at them in the lab, but they have quite different recovery. So participant A, that white line, reacts but then stays relatively activated throughout the recovery window, whereas participant B has their heart rate or blood pressure come back down when that stressor goes away. You can look at participant C, that red line, who has maybe a dramatic or exaggerated reaction to the stressor, but also shows relatively quick recovery. And finally, participant D, this yellow line, who has maybe a delayed or blunted reaction to the stressor, but then also stays activated. They don't really show a recovery pattern. And we think that it's this recovery window. What's happened when these stressors are not there? How does your physiology recover? That might be especially important for understanding risk for later health problems. So these biological stress systems are really designed to help us encounter short-term physical stressors often. So if you meet a bear in the woods, you want these systems to turn on and help you engage with that challenge. But where things become problematic are if you're not able to turn that off when a stressor is not present. We know from a lot of literature that having too exaggerated of a reaction to stress or not being able to recover are linked with poor cardiovascular outcomes. So individuals who have exaggerated stress response across a variety of studies show greater rates of subclinical cardiovascular disease and higher rates of morbidity and mortality. Similar story with poor recovery. And so given all this as background, we were interested in whether these cardiovascular responses to stress in adulthood tracked with the socioeconomic environment in childhood and adolescence. And given kind of continuing along this theme of resilience, we were interested in whether knowing something about an individual's well-being changed these relationships. Now, to answer this question, we're going to turn to a different sample. This is called the Paths to Healthy Heart study. And this is a sample that was a follow-up from the Pittsburgh Youth Study. I did this study when I was at the University of Pittsburgh. The Pittsburgh Youth Study started in the 1980s with a representative sample of boys in the Pittsburgh public school system. And these boys were tracked annually over their childhood and adolescence. And then more recently were brought into the lab for cardiovascular health assessments now that these men were in their early 30s. You might be thinking that early 30s is a little bit young to be looking at risk for cardiovascular disease. And while it's true that kind of peak incidence rates do occur later in life, race differences in cardiovascular disease and cardiovascular risk do appear this early. Okay, so what did we find? We didn't see any associations between childhood socioeconomic status and cardiovascular responses either at baseline or in reactivity to a stressor in the lab, but we did find that individuals who'd grown up in lower socioeconomic environments in childhood and adolescence had higher systolic blood pressure and heart rates in that recovery window from stress. But importantly, this relationship was moderated by psychological well-being. And so here the graph looks a little bit different. Now we have systolic blood pressure on our vertical axis and childhood SES on the horizontal axis, and these lines represent different levels of psychological well-being. So for individuals with relatively low or average psychological well-being, you see that expected socioeconomic gradient, where higher SES individuals have lower levels of systolic blood pressure at recovery, which would be the healthiest pattern. But for individuals reporting relatively high psychological well-being, there's no association between childhood SES and blood pressure at recovery. Now, this was just one study in a unique sample of men from Pittsburgh, and so we were interested in whether this pattern was consistent in the larger literature. And so to do this, we undertook what's called a systematic review and meta-analysis, where we gathered all of the data that was available on the topic of socioeconomic status and cardiovascular responses to stress. To do this, we found 25 studies with over 14,000 participants that had data on socioeconomic status and cardiovascular reactivity. And when we averaged these together in the meta-analysis, we did not find a reliable association. So this figure over here, the diamond at the bottom represents the overall effect, and right here this is a zero relationship between socioeconomic status and cardiovascular reactivity, and each of those lines above it represents an individual study that went into the meta-analysis. In contrast, only 6 studies, although representing over 1,300 participants, have looked at the relationship between socioeconomic status and how the cardiovascular system responded to or recovered from stress, And here we found support that across these studies, individuals with higher socioeconomic status had better cardiovascular recovery. So to summarize this part, the cardiovascular system, specifically in how it recovers from stress, might be a key biological pathway underlying and contributing to these health inequalities, but again points to a protective role for psychological well-being. So I want to introduce kind of 2 ways in which this work is continuing. First, kind of continuing along these lines of stress reactivity and recovery as important mechanisms. We're currently collecting data in Denver to see whether we can increase the salience of psychological well-being. And if we can do that, can we then change the way that the cardiovascular system responds to stress? This is, we think, the first direct test of stress reactivity and recovery as a mechanism through which psychological well-being may relate to health. And an important question that we're interested in are whether or not these effects might be stronger among lower SES individuals. So in addition to kind of digging into these mechanisms of biological stress responses, other work that I'm pursuing is kind of taking a step back and taking a broader economic factors approach. So we have some evidence to suggest that the socioeconomic environment of one's neighborhood might be especially important for individuals who are lower SES. So in this study, we looked at individuals, low SES individuals who resided in either higher or lower SES neighborhoods, and we found that low SES individuals in higher SES neighborhoods did not kind of exhibit the same they had better cardiovascular health. Another area we're especially interested in the impact of the Great Recession of 2007 to 2009, and the role of that in kind of increasing these inequalities, especially in cardiovascular health. So if you take home messages before I conclude, one is that there are, in fact, pronounced SES gradients in many health outcomes and biological risk factors in midlife and old age. Some evidence that anger might exacerbate and psychological well-being may buffer these health inequalities, and also the importance of recovery from stress and understanding how risk from inequalities gets under the skin to affect physical health. Before I take questions, I want to acknowledge the fabulous people I've had the pleasure of working with here at UW-Madison, at the University of Pittsburgh, and now at the University of Colorado, Denver, to all the MIDAS and PADS participants, the generous colleagues that I've had, as well as the funding that's made this work possible. So thank you.